Hello and welcome back to part 3 of our discussion of real movement. This is Adam Wolf, and today we're going to be talking about a perspective on fascia science. Up to this point, what we've been talking about is the criteria to what defines integrated motion. When I say integrated motion, I think about the connections of the body that work together to control forces of the body. If you're not familiar with what I'm talking about, please keep in mind this is lesson number 3, so I encourage you to go back to lesson number 1 and 2 to see what we've talked about to get up to this point. And so today what we're going to talk about over the next 30 minutes or so is hopefully further understand the importance of the fascial connections of the body. To do that, first we need to talk about just some of what the fascial science is telling us, because tradition and our traditional mindset and concepts of what we've been saying and to ourselves and as well as the people we work with is turning out to not necessarily be true. So we need to understand what is the current science showing. More and more professionally, I think about one of my favorite lines from my favorite movie, The Princess Bride, is I do not think that word means what you think it means. And more professionally, I think that sort of thought process applies, and this certainly is one, is like our traditional thought processes of what we've thought up to this point have been happening in terms of the mechanisms that we're using when we're touching somebody isn't always the case. We'll talk about that. We'll talk about specifically the current research that relates to fascia and soft tissue, and then hopefully understand a little bit about those concepts about how fascia and soft tissue work together, and that's what's lengthening to control the forces that are presented to the body. Remember that injury occurs, in my opinion, when forces are presented that the body can't handle as they're being presented, typically at the end of a transformational zone. And if you don't know what a transformational zone is, I highly recommend that, again, you go back and look at part 1 and part 2, where we talked about drivers and real and relative motion and all of those things. My experience is that oftentimes those that have pain that are coming in to us that need to improve and get out of pain, there's a number of things that we can do. I also see some commonalities between people in pain, including recognizing, one, that pain is an output, but typically people in pain run fight or flight or sympathetic dominance if we're thinking about the autonomic nervous system. Most times I believe that people that are in pain tend to have a sympathetic dominant nature to them. It's been proven through science that people that have a sympathetic dominant nature to them are not going to learn anything new. And one of the other clinical correlations that I've made is that if you have pain, you have some behavior change that needs to occur. It really just becomes a matter of what that behavior change is. And so we're going to talk about that. Another thing that I've recognized is that through science, it's been demonstrated that people that have pain have limited awareness of their selves in space. We think about proprioception being your awareness of yourself in space. Proprioceptors are found all through the body, particularly in the fascia. And so proprioceptors allow you to be aware of where you're at. And what happens is they tend to get inhibited, and we've defined that already, inhibited when they're shortened. They respond to getting long. Remember, we need to lengthen before we strengthen and go opposite first. And so Ida Rolf said that where you think it is, it ain't. I think that really holds true for those particularly that are in pain. Your awareness and where you think you're at in space oftentimes excuse me, proves to not be the case. You tend to find that you're not exactly where you think it is. I see that all the time. People will be working with me and they'll get off my table, we'll be done doing a particular activity, and they'll say, I feel like I'm off kilter, is typically what they say. And my response to them is, actually, you're probably more on kilter. Your perspective of what kilter has probably changed. We need to recognize that. We also need to recognize that all joints and all muscles work in all 3 planes of motion all of the time. That's just something we can't get away from, and that the body is triplanar, and that the body decelerates forces that are presented to us. Muscles can produce forces. We appreciate that, but what they're really going to do is control the forces that are presented to us in most cases. They can produce that force when needed, but most times they're just going to reduce force in all 3 planes of motion. Muscles are integrated, and the example is the soleus muscle, which I think from an isolated perspective we can say plantar flexes the ankle, but from an integrated perspective does a couple of things, including in static stance, keep the knee extended. We think about where it attaches, which is to the tibia, and into the calcaneus, the bottom of the bone. It's going to stop the tibia from moving forward in space. When I say move forward, we can replace that word with translation. So it's going to stop the tibia from translating forward in the sagittal plane. It's also going to stop the knee from it's going to slow the knee from extending as we're walking, and actually assist, if we think about with hip extension, the soleus can and does often help with hip extension. If we have a tight soleus and the soleus doesn't allow the tibia to migrate anteriorly, and that when your foot's behind you, when your right leg swinging forward, your left soleus, if it doesn't have enough length to allow the tibia to translate forward, you're never going to get hip extension, because the inability of the tibia to translate forward is going to cause a knee flexion moment, and off hip flexion, when the knee flexes at that point, the hip is going to flex as well. So the inability to get the soleus long and get dorsiflexion is going to result in the inability to get hip extension, and the ability of the soleus to get long at the second phase of gait as your right foot is swinging forward in space and your body is passing forward over your foot. So your pelvis is translating forward as your right foot swings forward. That pelvis translating forward makes your pelvis move forward. It makes it move forward faster than your left femur. It translating forward faster than your left femur because your soleus is slowing your tibia from moving anterior. It's allowing the femur above it to move forward faster. And that dissociation there, remember that motion is a synchronous dissociation. So the soleus getting long in the sagittal plane when it's behind you allows the femur above it to move faster, which allows the pelvis to move faster above it. So it assists not only with knee extension, but also hip extension. That's what we think about when muscles are integrated and not isolated. We remember that combinations of tissue work together to get long and control forces that are presented to the body. We can appreciate that. It's not only from the tendon to the bone to the muscle all the way through. We can appreciate that it's all connected in a continuum. It's interconnected is the best way to put it. So very often people, when they come into me, ask me, what muscle are you working on if I'm doing some body work and have my hands on them? One of the questions I like to throw back to them is, how many oceans are there? And what I mean by that is typically they say 7 oceans, sometimes they say 5, but that's a man-made construct. It's really one body of water. And the fact that man is differentiated into 7 oceans is important sometimes, but the reality is it's one body of water, just like it's one unit and one muscle that man has differentiated into as many as they have. Recognizing that that's a man-made construct. The body doesn't know what a muscle is. It knows what motions are and how to control the forces that are presented to it. And again, injury occurs when forces are presented to the body that it can't handle. And so remembering that it's interconnected, we see this picture here on the right, this model. This is an idea of tensegrity. And that idea of tensegrity, tension within integrity, I know I've mentioned it before in the first couple of presentations. And it's something that I utilize daily in my practice when we think about the body compresses and tensions together all the time. With compression comes tension. Think about those red balls there being bones floating in this network of myofascia, because the reality is no two bones in the entire body ever touch. And so when we think about these, and when they do, there's pain. We need to appreciate that. And so if I was to take 2 of those red balls and pull them away from each other, other of the balls are going to compress together. So with tension comes compression. Just if I take 2 of those balls and compress them, others are going to tension away. And so with compression comes tension. With tension comes compression. This is just one of the consistencies of the body that I utilize when I'm doing stretching and strengthening from an integrated perspective, as well as when I do my body work in terms of the grip that I take. I always compress into a level, and then I tension when I'm at that level to take up the slack in the tissue before I do anything else. And so here's another example of compressive tension, or tensive compression is the way that I think about it. If you've ever been to the Chicago, you look at the John Hancock building and it's got these cross-linked fibers which move up the building as they move. This is an example of tensegrity from a traditional architectural concept. The thought process, and while it's not a perfect analogy because we're not We're not buildings, obviously. This cross-link fibers provide mobility for these very tall buildings, which traditionally, when the support beams were stacked on top of each other, when the building would sway, the foundations would crack. So it was very stable, but it wasn't very mobile. And they found that if they can cross-link the support beams together, like in this picture of the John Hancock building, as this building sways, the cross links above and below compress together and allow tension in the middle, or the crosslinks in the middle tension to compress together to allow tension above and below. Depending on how you want to look at it, it can go either way. So with compression comes tension, and with tension comes compression. They found that this is the case in the body as well. There's some very good research that I believe it demonstrates this. A great book that illustrates it is called Biotensegrity, the Structure of Living Tissue, and it's by a guy named Graham Scarr, Scarr, who I think is puts a great product out. So the reality is fascia is what sort of binds it all together. I think about an analogy as the cookie. If you have a chocolate chip cookie, it's going to have the same components versus an oatmeal raisin cookie in terms of sugar, butter, flour, and whatever else I'm missing there. But we think about the combinations of what's needed to make the cookie changes, just like your bone versus your muscle versus your eyeball. It's all made of elastin, collagen, reticulin, in this extracellular matrix. It's just a matter of the combination of it, rather if it's going to be very stretchy or if it's going to be very stiff and or if it's going to be in between and be a little compliant. And so that's what we can think about with fascia. It's the ties that bind us together is what I think about. What we talked about last time, and we'll talk about a little bit more, is this interlayer gliding. I think that's really important that's happening. Tissue needs to slide past itself. It needs to be able to slide past other tissue. And when it's unable to, the result is this reaction which sort of binds the tissue together. Tissue needs to be able to get fully long to fully short. When it can't get fully long to fully short, the tissue starts to lose its pressure differential versus what's around it. When the tissue doesn't have as much pressure change versus what's around it, meaning if it can't get fully long and fully short, there's not going to be as much blood or fluid that's pumped through it. When there's not as much blood or fluid pumped through, there's not as much oxygen getting to the tissue. When there's not as much oxygen getting to the tissue, there's literally a chemical reaction that begins to bind the tissue together. And so then when it should slide past, it's unable to. And so improving and making sure that the tissues can glide, at least the tissues that are superficial, that I think we can maybe affect even in the short term, in its gliding ability, I think is beneficial. Certainly we're not changing the structure of the tissue. We're just, I believe, creating space between it. And what Jeffrey Bove talks about, and we talked about last time, is improving the ability of the interfaces of the tissue to slide past each other. Dr. Robert Schleip is a German guy who is kind of known as the father of fascia. He sort of debunked the idea that fascial release, or that we're deforming tissue. He's dismissed this thixotropic or piezoelectric effect. That for me, quite honestly, I had some cognitive dissonance around that. That was sort of what I had conceptualized for a long while. Thought about the tissue becoming fibrotic, but that's really, he's shown that that's not the case, and that really it's impossible to change tissue. What we're really doing is improving the gliding ability of it, because Dr. Schleip has shown that the tissue becomes densified. So there's a densification rather than a fibrosis that occurs. I do believe, though, that there are fascial changes that occur over time. Remember, if tissue doesn't get fully long to fully short, it's not going to slide past itself. And this, rather through a repetitive stress injury or whatnot, because we're going to move around pain rather than through it, there's going to be this lack of getting long to getting short fully on one side of the body versus the other. It's going to be a combination of tissues. And so relative to that other combinations on the other side, or front to back, there's going to be an imbalance that occurs. And over time, that compensation sort of results in this inability of the layers of tissue to slide past each other. And there's a myofascial restructuring that occurs. I'll show you this picture here in a minute, but that's kind of results in and kind of contributes to, or whether it results in or just contributes to feed forward or feed backward, I don't know. There's an altered movement pattern a lot of times. And over time, a lot of times, not all the time, certainly, but that can result in dysfunction and maybe pain. Certainly, pain's an output, and it's not an issue until it's an issue. But when it's an issue, we need to do something to change output, and oftentimes changing input is a great way, and improving the ability of people to move is a great way, and then getting tissue to slide is a great way to improve and lessen the threat to move a little bit freer, even in the short term. This picture we talked about before, it comes from Dr. Teppo Jarvinen. This picture on the left, it's the same picture on top to bottom, black on white or white on black. But Dr. Teppo Jarvinen spoke about this is the paramecium of a soleus, and the picture A here is what a healthy paramecium should look like in its ability. Notice that all the tissue is sort of aligned parallel on that sort of tangential angle there, and so all that tissue slides past itself, the superficial to the deep, what's left to right, long to short, short to long. There's all needs to be this ability to translate past itself. The picture on the right, picture B, is that same paramecium of the soleus, but it's immobilized for 3 weeks, 2 to 3 weeks. I forget exactly specifically, but you can see these cross-linked fibers that start to bind these tissues together that would otherwise slide past itself. Personally, I believe that you can feel this one side of the body to the other. If you were to ever watch me, and we'll get some videos and some lessons up showing some demonstrating this in the future, but you would see me touching people a lot and taking them through full excursions, full ranges of motion, and comparing and assessing their end range tissue and tolerance to tissue and spring in the tissue at end range. And I'm looking to see, when does the tension come into the tissue? Is it clean and all at once and how it comes into my hands when I feel it, or is it abrupt in one spot? And I think that when it's abrupt in one spot, particularly when it's different from the other side, and when there's pain, that can contribute, and that's one of these instances that there's the lack of slide, and that's what I'm feeling, is all the tissue kind of pulling together and coming up under my hand. And so when I say scar tissue, that's not necessarily a bad thing. I'm not talking about this picture here that I just showed you, what we were just talking about, this soleus. But when somebody has a true injury, for whatever reason, let's say that they tore their hamstring or that there's a actual pathological tear, we need to appreciate that this becomes part of the fascia. I don't want to talk a ton about this now, but scar tissue is important. We need to recognize that, but also recognize that when there's a true scar tissue, we need to ensure that that tissue is laying down in a logical and specific way, and we can do that through applying specific force to tissue. We'll talk about that at a future date as well, but the reality is also, when there's a scar tissue in terms of getting cut in the body, there are hundreds of thousands more sympathetic nerve innervations versus parasympathetic nerve innervations, and so the body is more connected. There's more of a fight or flight reaction. For me, it's not a matter of if a scar is going to cause an inhibition in the tissue around it. It's a matter of what the inhibition is going to be. We just need to recognize that. And so talk a little bit and appreciate scars more in the future. Dr. Michael Leahy talks about the cumulative injury effect, or the cumulative injury cycle, what I think about as a negative feedback loop as well. If you have an injury, let's say the inside circle is acute, the outside circle is chronic. Let's say you have a tear crush injury, which results in some inflammation, which we want. Inflammation is a normal part of the body. It's something that we want, but that inflammation causes an adhesion and fibrosis, which causes a weak and tense tissue. That weak and tense tissue causes friction, pressure, and tension changes in the tissue, one side or the other, which can cause another tear. So you can get caught in the acute, which can cause more inflammation, and then you're into this negative feedback loop. After a while, that friction, pressure, and tension results in decreased circulation and edema, that stagnancy for me results in a whole cascade of negative effects, including rigidity and the inability to get very long to very short. And so there's this negative feedback loop that takes place. Ida Rolf talked about tissue being locked long or short. If somebody's in a kyphotic position, you can't just have them stretch the front and strengthen the back. You need to work on the tissue to improve the glide of the layers on the front and the back, because short tissue can be adhesed, for lack of a better term. Short tissue could be gunked up or have the inability to slide past other short tissue, just like long tissue can have the inability to slide past long tissue. So when somebody comes in, we need to appreciate this and work to, through maybe manual works or creating pressure and fluid change pumps in the body, we can create and spur this inflammatory response to get over it. When people are in pain, I feel like they're stuck in a negative feedback loop a lot of times, and we need to change that, recognizing that it's been proven through science that those that are in pain have a limited sensation. Pain is an output, remember, but they have a lack of representation to the painful region in their brain. This study right here, I don't remember the specific study, but basically talks about, it's been proven that people that have pain, there was a study that was done that looked at people's ability to differentiate 2-point discrimination in their thoracolumbar fascia. Basically, what this slide says is that people without pain had the ability to differentiate 2-point discrimination at 3 centimeters. So when you touch someplace in the thoracolumbar fascia, whether vertically or horizontally, with 2 points, at 1 centimeter they'd feel 1 point. At 2 centimeters they'd feel 1 point. When you get to 3 centimeters, somebody without back pain would feel 2 different points. Those that had low back pain didn't differentiate 2-point discrimination to 6 to 8 centimeters, depending whether vertical or horizontal, which tells me that there's a lack of limited tactile acuity or proprioception in that region. What Dr. Mosley and Butler from the NOI group talk about is the smudging effect. It's sort of in your somatosensory cortex. That region is basically erased from the blackboard, you can think about, or nowadays whiteboards, right? And so when somebody's coming into us that's in pain, and we recognize that they're probably running sympathetic in nature and how their body is running, one of our main goals need to be creating a rest and digest, because if you have a behavior change that needs to occur, and for me, again, if you have behavior change, if you have pain, you have behavior change that needs to occur, we need to create parasympathetic dominance. You're not going to learn anything new if you're running sympathetic or fight or flight. And if you have pain, you need behavior change. And if you need behavior change, you need to run resting and digesting, or chilling the F out, as I like to say to my people that I work with. Although I like to use the F word. And I like to use the F word, tell them to chill the F out, because it creates giggling, and giggling releases endorphins, which stimulates parasympathetic dominance, along with breathing and all these other ways that we can change input to change output and stimulate parasympathetic responses. Because remember, we're working with the nervous system here most times, and the reality is when we're touching somebody, we're not touching the bicep or the QL or any of those regions. We're touching skin that's over that particular region. And so I think that's important. That's the best case that we can say. We're touching the superficial skin and over that superficial tissue over a particular region, and improving the ability to get that tissue to glide, improving through touch the ability to find that place in space a little bit more effectively, maybe improve tactile acuity, which improves input, which improves output. To improve the somatosensory cortex are all great ways to change input to ultimately, again, change output, because pain is an output. And so this picture here comes from Steve Capobianco, director of Rock Tape, and it's an illustration of what Diane Jacobs, physical therapist, the creator of dermoneuromodulation, it's his perspective. So we've got this brain. There's kind of 2 parts to the brain. And on the brain, at the lower part of it, we've got this other area called the cerebellum. And attached to that, we've got this spinal cord. And attached to the spinal cord, we've got different regions. Or even behind the rear brain, we've got what we can think of as the old brain or the reptilian brain. And then we've got the forward-thinking brain that makes us who we are. Attached to this spinal cord, we've got these nerves that go around. And attached to those nerves, which are an extension of the brain, because the spinal cord is an extension of the brain, and the nerves off the spinal cord are therefore an extension of the brain. We've got the skin, which is attached to those nerves, which are attached to the spinal cord, which is attached to the brain. And so we've got this connection to the skin, which the reality is, embryologically, it's been proven that your skin is an extension of your brain. As soon as your brain begins to develop, so does your skin. So your skin is an extension of your brain. And if you have pain and you have less representation to that particular skin, that tactile acuity, what we just talked about, you have less space in your brain. So using our hands to create awareness of particular places in your body, and also improving the glide, and also improving the lessening sympathetic output, can help to change output, because we're helping to change input. with also breathing and all these other things. Here, I'm on a roll here, man. Woo. So when we touch the body, we're getting all this input up into the brain, which helps to change the output. I think this is a really good picture. When we're touching the skin, we're touching different receptors depending on if we push hard, or if we push fast, if we push with vibration, if we push to, are we touching skin to change pain, and we're probably going to go a little lighter. So there's various ways and various receptors in the fascia that we can work with and access based on the approach that we're taking and how we're gripping that fascia. We'll talk more about that as well. Remembering that there are always going to be asymmetries in the body inherently, because the body is set up asymmetrically, attachments of the psoas into the diaphragm and heart on one side and lobes of lungs and all these pieces. So there's going to be this inherent asymmetry, which means that there's going to be some tissue that's long and some tissue that's short. I think about us being bike mechanics. If those of you that have ridden a bike, this picture up on the left, you've got this bike wheel up here. If you've ever ridden a bike and you've got a loose spoke in your bike wheel, you can't just tighten one spoke, because the spoke exists on the bike rim in a length tension relationship. If you just tighten one spoke on this rim, which exists on a length tension relationship with the other spokes, you're going to bend the rim out of shape. So as a body worker, a movement professional, someone who's trying to help people get out of pain and move a little bit more efficiently, we can't just true a particular body part. We can't true the knee. We need to true the entire system. That's what it's called, is truing the wheel. When you go to a bike mechanics and they fix it, that's what they're doing, is truing the wheel. And that's what I think about for us. We have to remember that it's all connected. And it's connected, what I think about, we can think about as through fascial highways, or these fascial connections, as my father Chuck Wolf says, flexibility highways. But I just think about these, while they're man-made, these fascial connections that, while they can produce forces together or separately in isolation, they can also, what they're really going to do is control forces that are presented to it, and they're going to control the body moving in all three planes of motion. So I think about these fascial highways, or these fascial lines that connect them. And we're going to talk about that next time. That's our next lesson, is getting a little bit more specific with what some of those fascial lines are. In conclusion, where you think it is, it ain't. If you don't know more about Ida Rolf, I really suggest you get knowing about her. She's a pretty fantastic lady. Combinations of tissues and joints work together to control forces, and I believe that injury occurs when forces are presented to the body that the body can't handle. We need to recognize that tissue needs to slide past itself, and that we are not breaking adhesions. Okay? We can appreciate that within the spectrum of motion, we can take a movement static to dynamic, and that it's all governed by the nervous system. So that's what we sort of covered from here. Where we go, we're going to get more specific next time. So next time, while there's only a few, we're going to put a few others up here. We're going to talk about specific fascial lines. We're going to talk broadly about the concept of integrated isolated spectrum. We're going to discuss naming three-dimensional movement and having the appropriate thought process to be able to understand what motion is happening in all three planes of motion for pretty much any activity. Which will give us insight as to if it's happening or not, and if it's not, we need to ask why. We're going to talk a little bit more about motor control, both specifically and generally. We're going to talk about tensegrity, which again I think is really important, and a concept that I used in my stretching, strengthening while it's integrated, as well as through my body working. We'll talk about that spectrum of mobility to stability a little bit more, and there's just going to be more. This is just the beginning. We're going to try to do these 30-minute workshops here, or lessons at a time. So meet me here. Catch me at Adam at Real Movement PT, Facebook, Instagram, YouTube, Adam Wolf PT. You can get me on my website at Adam Wolf PT. And what's next is going to be the fascial connection specifically. And if you have not done so, check out the other offerings that we have at adamwolfpt.com. Thanks.